Good morning, everyone. Welcome. I thank you for joining this learning series webinar, The Road to Recovery. As it is September, National Recovery Month, we're so glad to be able to explore this topic with you today. And as we continue to develop solutions to prevent addiction and death, we're also celebrating those in recovery and remembering those that we have lost. Some housekeeping. Today's webinar is designated for 1 AMA PRA Category 1 credit, 1 ANCC contact hour, 1 ACPE contact hour, 1 AAPA Category 1 CME credit, and 1 ADA CERP continuing education credit. And for the pharmacists who are on with us claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by New Jersey OEMS for 1 EMT elective credit. And PA Planner Dean Barone discloses that he serves on the Speakers Bureau of Ethicon, but all other faculty and planners have nothing to disclose. Today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I thank them for their partnership and their support and collaboration on today's learning activity and throughout this year-long learning series. And I thank all of you as well for joining us. I'm so pleased to welcome today's expert panelists. We have Iris Jones, who's coming to us from Cooper Center for Healing at Cooper University Healthcare, and Keith Cluse, who is a person in long-term recovery, and he works with community outreach at Hackensack Meridian Health Carrier Clinic. So thank you to both of our speakers today. So pleased to have you with us. And without anything further, Iris, I will turn the presentation over to you.
Thank you so much for that warm welcome, Angela. And so today I'm going to just take a little bit of time to talk with you all about the road to recovery and taking care of patients in a whole holistic way. Next slide. And this is just a little bit about me, and we can just skip right over that. I have no financial disclosures. Next slide. And our goal here is just to understand some of the guiding principles of recovery and understand how to support patients through the recovery process, and also to learn a healthy respect for autonomy in recovery and how that plays a vital role in our treatment planning and our positive patient outcomes. Next slide. So how do we define recovery? How do you decide that somebody is recovered? Is it abstinence? Is it they've returned to work? Is it parenting? Is it the resolution of legal challenges? How do you say someone is recovered? Next slide. And I'm going to tell you, coming from a background of behavioral health and from healthcare, we love metrics. We love to say how many urine drug screens were negative for positive substances, how many sessions someone attended, how many programs they completed. But my question to you all to think about today, is this actually recovery? Are metrics recovery? Next slide. And so we have a quick poll question here. And for those of you who know what medication for addiction treatment or medication for assisted treatment, how many of you think that a patient should be on it for a year or less, or 2 years or less, or indefinitely? And I'm gonna give you guys an opportunity, just about 45 seconds to choose and get a better understanding of where our crowd is at today. Just another 10 seconds for you guys to pop in your votes, and then maybe we can see the poll. .400 responses. All right, are you guys able to put the responses up so we can see what our team thinks? Okay, wow, we've got a good mix of people thinking indefinitely, and about, a third and a third thinking a year or 2 or less. We're going to talk a little bit about that. Thank you so much. Next slide. So when we're thinking about traditional recovery, are we thinking about a public health crisis, a public health emergency? And so what is the difference? Next slide. And so when we're thinking about a public health crisis, I'm thinking about the fact that 1 million people have died since 1999 from a drug overdose. 1 million people. And so I'm not just thinking of, oh, hey, I want to help somebody be in recovery from some occasional substance use and help them get better, right? And this is just going to make their life better. When I'm thinking public health crisis, I'm thinking I want to prevent this person from dying. And how do I go about doing that? Next slide. And so traditionally, and you guys can just pop answers into the chat, how have we helped people enter recovery? What type of treatment have we offered them? CT, methadone, oh, lots of responses coming in. Rehab, Suboxone. Interesting. Next slide. Thanks everybody for your participation. Well, early treatment was self-help and therapeutic communities. That's right, TCs, where residents all got together and worked with peers who had been through or were going through similar experience, and we tried to push people into recovery. And so we came down on them and we were really hard on them, or we had a self-help recovery moving AA, which allowed people to meet with other peers who could understand and guide them through the recovery. But later, we moved to some group and individual counseling by peers and then later professionals. Next slide. And then luckily, we moved into some evidence-based counseling, right? And these are just some of them, cognitive behavioral therapy and craft. And we tried integrative approaches in counseling and lots of matrix models. And that was integrated around using all of the evidence-based counseling that we could find. Next slide. But a lot of people ask me, especially family members, why does treatment fail? What is going wrong? I've sent my son or daughter to 17 rehabs and 6 IOPs. Why is this failing? And the thing I want people to walk away knowing is that addiction lives in the physiological. It lives down there with food and water and sleep and sex, right? It lives down here. And when we're doing counseling, even if it's evidence-based, it's in the love, esteem, and self-actualization space. So what Maslow says is if I haven't met the needs on the bottom of this pyramid, I can't start working on the rest. So if I am hungry and I am sick and I am in withdrawal, it's really hard to talk about how I'm going to improve my relationships. Next slide. And so that's why treatment often doesn't do as well as we want it to do for patients. And really understanding that addiction is a chronic disease. And what I mean by chronic is it's preventable, it's treatable, and people die if we don't treat them, and people die if we don't take care of them. And it changes the biology, it changes the neurobiology of our brains, and it changes our bodies. So it falls into the same chronic disease space, next slide, as diabetes and high blood pressure and asthma. And so often families want to know, they keep relapsing. Is this supposed to be a part of recovery? Are they really in recovery? Here's the thing. People with diabetes eat sugar and they don't exercise all the time, and people with asthma smoke and high blood pressure eat salty foods. And never once has someone walked into their doctor's office and say, oh, hey, your A1C is still up. I can see you're still eating non-healthy foods. I can see that you haven't exercised. I'm taking your insulin away from you because you're making poor choices. We don't punish people for not doing well when they have a chronic disease. But addiction, it's a little bit different, right? We're like, oh, we're going to take away your medication if you don't do X, Y, and Z, or you tested positive. And so now we're going to discharge you from treatment. It has been very punitive in nature, and that is why people can't get better. Next slide. And so when I talk about addiction, I often talk about ACEs, and those are adverse childhood experiences. And we don't have time today to go deep into that, but just know the bad things that happen to us in childhood, they don't just go away because we grow up. What that means is the bad stuff stays with us. And so sometimes we can adopt high-risk behaviors, we can have mental health, then we can have diseases, and then we can die early because of the bad things that happen to a child. Abuse, neglect, experiences like that. And so what we know as a nation is that we have some pretty high ACE scores. So it's no wonder that substance use continues to go up. Next slide. And we also know that addiction is an attachment disorder. So attachment, think of it as our ability to connect with other people. And so when addiction impairs our ability to connect with other people, we end up isolated and we end up alone. Next slide. And so if I've got addiction and I've got trauma, and both those things live together and they hurt my ability to connect with my family and friends, they hurt my ability to reach out to others, it's no wonder that people aren't able to connect with treatment providers sometimes. It's no wonder that that feels really hard for patients and they're not sure where to go or what to do or who to trust when they're in this vulnerable state. Next slide. I loved the old ASAM definition of addiction. They have since moved on. But this one for me really hit home when they talked about addiction as a primary chronic disease of the brain, and that it changes us biologically, psychologically, socially, and spiritually. And so this affects our whole person. It doesn't just affect our physical health or our mental health. It doesn't just affect our relationship. It affects our whole person. So when we're thinking about treatment and recovery, we have to think about treating all those aspects of the whole person. And the other part of this is that when people are in an active addiction, they may not recognize that their behaviors are problematic, or they may not recognize how important their interpersonal relationships are to them. Because right now, their brain is hurting and their brain isn't able to connect with other people. And they're having this dysfunctional emotional response, but they can't see it when they're actively using. So when a parent says to me, that's not my daughter would never behave this way, I don't know who that person is. And I'm like, right now, when your daughter is actively using, she's not your daughter. She's not the person that you raise because her brain is broken. Next slide. And so when we're thinking about addiction, another important thing is it's not just affecting the individual that's sitting in front of me, it's affecting their entire family system, whether that family system comes into treatment with me or not, right? If they're using, they're not home parenting their children maybe, or they're not home supporting their elderly parents, or they're doing things that are hurting their family. So I have to think of each patient and each recovery as not just recovery for one individual, but recovery for an entire family. And because of all the hurt and harm in these relationships, people may not feel comfortable with including their family, or the family may not want to be a part of treatment, but I'm still treating the whole family system. And that whole system needs to recover in order for people to do well. Next slide. And so I do perinatal addictions as a specialty, perinatal mental health and addictions. And so I take care of pregnant and people with substance use and mental health. And so here in this slide, you have this pregnant person, and all she wants to do is get to a place of recovery. She got pregnant, she wants to get recovered. But guess what? She needs insurance. She needs to find a provider that takes her insurance. She needs to find a provider that's willing to take care of a pregnant person. She needs to have a safe and sober household to hold her medications, right? She has to have childcare because she's not allowed to bring her children to treatment. All of these barriers. And we only have a few places where pregnant and parenting people can go to get help, where they could go inpatient if they need it. The research shows that only about 1 in 10 receive the treatment that they need. And so once they've navigated all these pitfalls and all these barriers and get to a place of recovery, next slide, they now have to get to a place of parenting or reintegrating with their family. But guess what? All the stuff that they did in their active addiction, it catches up with them. And that means that they have evictions on their history, so they can't get a new apartment to live in. They have a criminal record, so they can't get a job. They have municipal fines and license suspensions, so they can't drive a car. So all of this compounded things or behaviors have resulted in their inability to even get back into their lives once they hit a place of recovery. Next slide. And so we're often taught as professionals about these stages of change, and we're taught that a patient can move through these stages of change, and that is good. But stages of change aren't linear. I can have a patient that has been sober for years and something goes wrong and they relapse. So they can go from a place of maintenance to a place of contemplation about whether even or not they want to be sober anymore, because things feel so hard in the blink of an eye, it can happen. So grounding in on stages of change isn't actually the best way to support somebody in recovery. They've got to decide where they're at in their stages of change and what they're ready for. Next slide. And so when we're talking about addiction and chronic addiction and severe and end of life addiction, people aren't having fun anymore. And I really have to hone in on this. People are not enjoying. This quote hit me so hard that end stage addiction is mostly about waiting for the police or someone to come and bury you in your shame. It's about waiting for death. It's about waiting for incarceration. People are not using to feel good. They are using to feel normal, and then they're using to stay alive. And so keeping that in mind when we're taking care of patients in a public health crisis, we need to have so much empathy for them. Next slide. And we love our moral compass because we've always thought of addiction as a moral disease. We've thought of it as somebody making poor choices. And so even when we think about high blood pressure or diabetes, we're like, exercise, eat right, go to nutritional counseling, and everything will be fine. But behavior change is hard. Behavior change is challenging. Think about how many times you thought about, oh, I'm going to start this diet, or, oh, I'm going to start this workout plan. And you did it for a little while, but you didn't stick to it. Something came up. So, and that's like just behavior change. That's not chronic disease. So when we're thinking about using our moral compass to say, hey, you can do mindfulness and meditation and you will get better, that's just not the way. That's not a holistic recovery picture. That's not going to keep people alive. Next slide. I love this slide because it paints a really clear picture of not just trauma, but addiction. And I can't go heavy into this brain neurology, but I want everybody to think of your limbic system as your horse. And this is all your driving behavior is coming from this. And your prefrontal cortex as your rider. And your rider is supposed to control your horse, right? It prevents you from just deciding that I'm going to leave the house naked today because I don't want to put on clothing, right? Your rider's like, I don't think that's a good idea. But what happens with trauma and what happens with addiction is that your rider isn't in control anymore. Your limbic system, your horse is running around, it's knocking people over, it's damaging things, it's hurting other people, and it is driving your behavior. And it is driving your behavior to get to those substances, and your rider has no control. So again, when people are like, I wasn't myself when I did that, they're right. Their higher brain functioning was offline and they weren't themselves when they did that. Next slide. And so for people to change, they have to have the ability and resources and the willingness. But they also need things like empathy, self-efficacy, or belief that they can change, positive interactions, and the belief and the ability to start talking about change. If I feel like it's hopeless, if I feel like I don't have alternatives, I can't change. And so one of my favorite interventions is MI, because I am here to walk a recovery journey with someone, to help them become willing and able to change, not by telling them what they need to do or what they should have done better or how wrong they are for not having changed. Next slide. And so recovery with Matt is still recovery. Whatever your recovery looks like, it's still recovery. And because my goal is to prevent people from dying, I'm going to start with medication when I can. And I'm going to work on all the other things as part of recovery plan, as part of a holistic plan. And I'm going to support them wherever they're at in their recovery. Next slide. And the reason why this is so important is because if you see here, when people with opioid use disorder do not receive treatment or medication, and by treatment, I mean medication, they are 6 times the general population mortality, 6 times. And with medication, they're just a little over 1.5 times likely to die. And so for me, for my loved ones, if they are struggling with addiction, do I want them to die at 6 times the rate of the general population or at 1.5 times the rate? And I don't know about you, but 1.5 times the rate is it for me. I want to do everything I can to protect my family member and to protect my patients. And for a lot of patients, that's going to mean medication. Next slide. And so what we also see is when people are given medication and support and therapy and all the things that they need, they are given the ability to reintegrate into society. They are able to obey the law. They're able to stop acting out in ways that we don't like. And when people don't have treatment, they end up right back in incarceration, unemployed, struggling with infectious diseases, overdosing, and dying. And we've always thought of abstinence as the key. The thing about abstinence and the thing about tolerance is why somebody is using a tolerance is protective for them. If they're using a few times a day and their body can handle that, And then all of a sudden they go into a detox and they become abstinent and their tolerance goes completely down. Then they use once and they overdose and die because they didn't have that tolerance. So we have to be mindful when we're saying just quit, just stop, right? Because even after that tolerance is gone, they are at higher risk for death. They are at higher risk for death once they've done a detox. They're at higher risk for death once they've been incarcerated if medications have been withheld from them. Next slide. And so again, one of my favorite interventions is motivational interviewing. And this slide is so important because what we want as providers change to look like is I give you intervention A, you get to place B, it's a straight line. There are no problems, there are no hiccups because I gave you these meds and I told you what to do and I told you how to be better. But what change really looks like is we started okay and things went a little badly and we got moved around the tree and then you came back and you dropped out and you came back and you dropped out. And sometimes you're ambivalent about even your desire to want to change. You don't know if you want to do it because it's so hard, right? But I'm not going to confront you. I am going to support you because if I can help you resolve ambivalence, I can help you get healthy again. Oh, I'm so sorry. Sorry, team, my computer locked. Next slide. And so why don't we do this? Why is this so hard for us? Well, one of the reasons is because of our own bias, because we think recovery should look like a certain thing or it should go a certain way. We have our own histories and we have how we've been exposed to substance or how we've been exposed to recovery throughout our lives, how we have been exposed to family and what our family members have done or how we've been hurt by people who are in an active addiction. And so we've got to acknowledge our own history and we've got to acknowledge our role and responsibility and also the bias in the system that I work. If my system says discharge a patient after 3 positive urine screens, and so I just do what the system is telling me to do, there's a little bit of bias there too. So we've got to look at that. Next slide. We've also got to look at our writing reflex. This is the idea that we're the expert. We can just tell patients what to do. And if they don't do it, we can blame them for their setbacks, for their relapses. We can tell them, you know, I told you so. I told you that if you went down this pathway, things were going to go bad. Because that writing reflex has never helped anyone get sober. Next slide. So the one thing that's always really hard for us to respect as professionals is autonomy. And that is the ability for a patient to control their treatment course. And that's hard because sometimes they're not making the right decisions. And that's really hard because sometimes we're watching things spiral out of control and we want to tell them, hey, if you continue this, then this. But this is why harm reduction is so important because not everybody is going to be ready to be sober the moment they walk in your office. Next slide. And so we engage in lots of stigma because of our bias, but at the end of the day, stigma stops people from coming into care. If I know that when I come into treatment, I'm going to be treated like crap and I'm going to be talked down to, and people are going to tell me all the things that I did wrong, why am I going to show up there? Next slide. And what it looks like for us is unkindness and an unwillingness to treat, unwillingness to learn about the patient and instead talk to or at the patient about what they could be doing better or how they should be doing better because you've done everything in your power to help them. So at the end of the day, they're really at fault for their disease. Next slide. And so I love this quote from SAMHSA. This happened back in 2004 and basically told us when we use language to inform and clarify and encourage and support somebody, they get better. And when we use language that isolates them or embarrasses them, they get worse. And we knew this in 2004, and yet we still use words like addict or clean or dirty urine. Next slide, words that make people feel ashamed. And so when we're changing our language to non-judgmental language, I'm changing the people's perceptions and attitudes around me, which means I can change policies. If I'm like, oh gosh, here goes Iris again, she's using again, I can't believe she relapsed, it's going to look very different than I'm like, oh, Iris is here, I'm so glad she showed up, she's struggling right now. People are going to respond differently. Next slide. And so I want to create safety and move away from words like frequent flyer or entitled or drug seeking. None of that has ever helped a patient. Next slide. And again, these are just some words we want to avoid, and you guys will all get these PowerPoints, but there's no addict, there's no junkie. We don't use that language. It's hurtful and it's harmful, and it causes people to want to use more, not less. Next slide. And so again, we go to this trauma-informed space. And what that means is we use strength-based framework, recognizing that more of us have trauma than don't. more of patients with addictions have trauma than not. And so we're going to treat them like they all possibly have trauma and come to them and create a safe space for them to get better and give them control and empowerment, give them control over the direction of their treatment, because we don't want to react their trauma by making them feel helpless. And if there's anything that people who have gone through trauma feel, it's helplessness. Next slide. So we've got to change our cultures. We've got to work on our sense of helplessness. We've got to change our policies. We've got to change our bias. We have to change our beliefs. Next slide. And so we've got to find common ground and mutual purpose, because that's the space in which people get better. People get better when we stop looking at things as black and white, or they're sober or not sober, or they're recovered or not recovered. We've got to find common ground. And when patients are sharing something with you, believe them. It doesn't have to be 1000% true, but that is their experience. That's what's happening in their brains and their bodies. And we've got to trust their worldview and stop coming down on them for not seeing things the way we see them. Next slide. And having hard conversations is necessary, but listen to learn and not just respond. Normalize whenever possible. Respect your patients. Be kind and clear and concise and empathetic, because again, this is the space in which people get better. Next slide. And so what we need is multimodality treatment. People need family and friends and communities and medication and support and therapy and food. People need all of this to be better. They can't just be better because we say, here's this med, off you go, you're better. Here's this, IOP, off you go, you're better. People need it all. It's really hard to stop using when you are homeless, right? So they need this really holistic care, and that's our job to provide it. Next slide. And so SAMHSA has a whole office that works on the Office of Recovery, that's worked on these definitions of recovery. And they've given it dimensions of home and health and purpose and community, of hope and respect. All of these things go into recovery. It's just not one recovery. It's just not one way. Next slide. And so here at the Center for Healing, we have low barrier integrated treatment that addresses trauma, that addresses social determinants of health, that supports patients wherever they are, whether that's food, whether that's clothing, whether it's, I'm not ready to get sober, but I want to come in and do art, whatever it is. The goal is to meet patients where they are, because in that space, that's when patients get sober. Next slide. And again, yoga, another thing that has been so helpful, right, as a part of a comprehensive treatment plan for moms who want to parent. Again, my special space, diapers, strollers, all the things, this wraparound care, because evidence shows with wraparound care, outcomes do improve. Next slide. So again, this is just one of my favorite quotes. We didn't know better back when we were doing therapeutic communities and when we were shaming people, but we know better now. So we had to do the best we could then, but now we can do better. And for patients who are using the active substance use, that's not as good as it gets. It can get better, but we have to believe in that for our patients. Thank you so much. Angela, I'm going to turn it over to you.
Thanks so much, Iris. What a really comprehensive presentation. Appreciate all that. And thanks to all of our attendees for your feedback in both the survey and answering the questions. So it's great to have that interaction. Keith, I'm going to turn the presentation over to you now. Welcome.
Great, thank you. You can go next slide. What is recovery? So, today over the last actually 24 hours, I've been thinking about this question a lot, and it being around September 11th, because I had family members that worked for the Port Authority, luckily escaped with their lives in September 11th. It makes me think about, how many people were lost over that time. And over the last 24 hours, I started watching a lot of documentation about it and all that kind of stuff. And I see 2,000 people, 3,000 people. And then I look at the opioid losses, and they're 3, 4, 5 times that amount. And, in my history, just to see the faces that have come and gone and pass away, it just breaks my heart. But it's just fitting that, September 11th and Recovery Month is during the same month. And, it just shows that, recovery is part of the process. And just like September 11th, we're all still recovering from that. But recovery to me, in my personal experience, is change, constant change. Iris hit a lot of great points there on how much change. It's just not a straight line. My personal experience with it is I was not a first time winner. It wasn't the first time. I didn't go to treatment one time or get a medication just one time. For me, it was 14 times I went to treatment. Eventually went on to, I had to go, I say the state program, which, prison was my end result in my story. But, recovery, every time I went to treatment, I gained a little piece. I gained a little piece of hope. I gained a little piece of knowledge. And I gained a little piece of my change into the next step of recovery. So as I start to progress through and understanding what my stages of change were and identifying when I was moving into a different stage and figuring out how do I continuously maintain. A big issue for me early on in recovery was environmental and social difficulties. That's why I put that on there as a point, because it's always, that environment, people, places, things that we keep on knocking into. We have all good intentions when we're in treatment. I can't tell you how many times I was sitting on day 27, sitting there and saying, I'm going to go home. Things are going to be different. I'm not going to do this to my family and loved ones anymore. Things are going to get better. And it's not going to be the same thing. And then I get home, I turn on my phone, and all these text messages start coming through with all these people. Hey, where you at? I have these bags, $5, $10, all this stuff, and you just get bombarded with it. To where if you're not well prepared, and when I was going to treatment, we were not as far along as we are now. It was very much 28 days, go home. We might set you up with an IOP program. If you don't have a place to live, we'll get you a sober living in Oxford House, where you're living in a house with a bunch of different addicts or something like that, and good luck. I think now we've started treating more of the whole person, which I like to see. From a professional side, looking at people when they start to recover, I look for that change in them. I try to see that optimism, see them start to pick up on things, see if they start moving into a new form, see if they start changing their habits. That was a big thing for me as well when I came home, was changing my habits, changing who I was hanging out with, changing where places I ended up in, just keeping in mind, all those things. So, as we recover, we start identifying this stuff much more. It starts getting much easier. I just celebrated 10 years in November. So, it's looking back, I still do a lot of the same things I did from day one in that, when I first made it into recovery, because I have to. This is a thing that I understand it's a disease that I have to stay on top of, because just like any one of my patients, a slip can happen if you're not vigilant, not on top of this like you should be. Next slide. Entering recovery. What is treatment? Treatment is a learning experience. I feel it's learning about yourself. It's almost like college for this disease, giving you the tools to arm yourself against this. Understanding what the warning signs are when the slips are starting to happen. It's funny, even to this day, sometimes it'll pop in my head something a counselor said in 2006. They said something to me and it pops in my head, and it makes me stronger throughout my day. So, as professionals, that's a good thing to be able to do, because the things we say do matter. When are you in recovery? When you say you are. This is something I learned through my recovery coach training and CADC training when I decided to become a counselor. Learning that you are in recovery when you say you are. There's not one square box, one square hole into what recovery is. We've gotten very progressive as far as what recovery looks like now. Before, it was very one-dimensional. 12-step AA program was one way, the only way. Now we have MAT. Now we have so many different ways to explore recovery, learning recovery, and progressing through recovery. Really, the thing is, you have to have that self-perception that you are in recovery, that you deserve that recovery, that you're moving into that recovery, and constantly doing a checkup, making sure you're moving forward. My one saying I say to any of my patients, and I say to myself often, is, if you're looking back way too much, you're not going anywhere fast. So always look forward. Things must always be changing and getting better. My experience with helping others in early recovery, the difference between doing it professionally versus in the recovery community. Helping others in early recovery, I remember that was the first thing I really wanted to do when I came home and ended up in recovery, was being in fellowship, helping people, driving people to treatment, getting them help. Not knowing the war I was stepping into. It's when you're doing it in the rooms of AA, it's very much different. You see people leave, you see people go, you see them again, and you're constantly in contact with your network that could help you through some of those situations. It wasn't until I moved into helping people professionally that I started to see the mounting losses and dealing with, death really on a large scale. I work for a very big hospital system, and we help a lot of people, and just to see all the people that have come through, and some that do make it, and then just some that don't, so it's in the fellowship. When you're doing that, when you're helping people, it's to help you move forward. When you're doing it professionally, you have to take yourself out of it, which and I tell any of my coworkers this, you have to take yourself out of it, because you can burn out. You can have any kind of issues where things start to go awry. You might identify too much, and you have to be able to understand that and accept that. And you have to be doing it for the right reasons. Just because I'm in recovery does not qualify me to help somebody. You have to have the understanding that you need to take yourself out of it, that you need to be able to identify when your story can help somebody and when your story is not going to help anybody. How your experience works, how you can push them through the next step in their recovery. It's very less selfish. In recovery, we tend to be a little bit more on the selfish side, to work on ourselves. When we're helping others professionally, we have to be less selfish, and and then work on our own self-care when we're not at work. So, learning that was a huge step for me. I've been in this field over 10 years, and it's just, I had to really understand that difference once I got into the clinical world and all that kind of stuff. And just really understanding that I have to do that separation. Next slide. Continuous support and recovery. Outside support, maintaining recovery barriers exist, and what services are lacking. That outside support is truly one of the most important things. If going back to people, places, and things, if you have a strong support system, it really gives you that extra step in the right direction. As Iris was talking about, and something that frustrates me on a regular basis is you have this person, and when we are talking about the system, we're trying to fit them in this small box, which is, what recovery should look like, which is very much different than what recovery really does look like. So, trying to take different pieces of different stuff to get through barriers. I can't just be like, hey, yeah, you should do an IOP program because your insurance doesn't cover inpatient therapy, but you also don't have a car to get there. And you also have no place to rest your head after you leave treatment or eat, so treating the whole person and understanding that we have to treat the whole person and their life, all of their life, just not that one section of their active use is extremely important. We a lot of times we forget that, what's going on with them when they come in here. And that's why we do a biopsychosocial. This is why we go through so we can identify that. Sometimes though, unfortunately, the services out there don't match up. As Iris was saying, prenatal care, that's one of the biggest ones. It's very hard to find stuff for prenatal. Also, adolescent is the new on the rise. We're seeing more and more younger teens coming in, and there's just not a lot of services out there to get them the help that they need. It wasn't so long ago, we weren't seeing 10, 11, 12, 13-year-olds coming in starting to use heroin. Now we are, and that's something that is a huge barrier because there's not treatment for that. We have some mental health treatment, but we don't have treatment for that. So understanding, the lack of services, and that's really where we're lacking, and understanding, and housing is another thing that kind of grinds my gears every once in a while, is because we do have housing out there, but it's not as expansive as it should be. Unfortunately, the end of someone's, addiction or their use, a lot of them end up homeless. That was my story. I went from a scholarship guy that had a scholarship to college, living on top of the world, to homeless in Manhattan. And, when I needed those services, they just clearly weren't there. If you didn't have insurance, you didn't have any means to pay, you might be able to get in some type of halfway house where it's not the greatest environment. So now you're putting somebody in a not so good environment. So, I think that's a place where, if we had more of expansive housing, where things could be more cohesive to the recovering addict and what they need, so we can work on those things like, hey, you need a job. Hey, you need a car. Hey, you need, you need to go to the doctor, even these simple things, and understanding that. What's been important to me in my recovery journey is, just the growth in my family, having my family back in my life. But thing that has been the most, I have to say, the fellowship of the fellowship, especially in early recovery, it was a game changer for me. You know, um, I've gone to AA, I've gone to NA, but I never really tried it or did it. So when this time around, when I decided to actually put the work in, and really do some self exploring, you know, that has been super important to me. And, you know, learning about myself, learning about what makes me tick, you know, learning about what makes me, you know, start to obsess over certain things. You know, my wife has come to find out I'm very obsessive compulsive. You know, we find out these things about ourselves that we have to work on, you know, and then we continue to work on them every day, you know. But you know, also the life recovery that, you know, the life that recovery has given me is also exactly what the promises are, is a life beyond my wildest dreams. You know, I just bought a house this year. I have a baby on the way. He's due in January. So, you know, things I never thought, you know, I would ever have in life. You know, I finally feel like I'm worth having it, and that I've worked hard to have it, and I'm doing the right things to continue to have it, you know, and understanding that nothing is just given to you, and you have to work hard for it. And you know, the fellowship of AA, the things I learned while I was in treatment, you know, was also you know, those pieces I've also taken with myself. Um, Also coming back to work at the place that was my last treatment. You know, my last treatment was at Carrier Clinic before I went away, and you know, they afforded me a new job, when I came home, and you know, I've been there ever since. And you know, I count my blessings they gave me that opportunity. So, you know, just these things that that are handed to you, and I love my job. You know, I get to help people. You know, that what other better job is there? You know, and that's the wonderful thing about, you know, medical field, you know, being in this field, is our job is to help people. It can be super stressful. You know, sometimes we want to make people do stuff, and you know, I try to, sometimes I just want to shake them, you know, and tell them like, hey, this is how it should be. But I know that would have never worked for me, you know. So you know, they have to find it themselves, and you know, learn it themselves. But you know, it's super gratifying, and it's wonderful I get to do that. Stigma. I want to touch on stigma, because stigma is something that kept me out of the rooms for a very long time. You know, that shame, that guilt of just even admitting that I had a problem, how the world perceived, you know, it was, oh my God, heroin, you know, it's like, and now it's not acceptable, but there's a lot of people that have had issues with this. So when you hear opioid addiction, it's not, back then especially, it was, oh my God, your son's doing, you know. So it's just, you know, that stigma that we put on ourselves. We got to remember, you know, the people that are coming to us also stigmatize themselves, you know, and understanding that it's our job to help change that perception to them, so then they could accept the process that they're going through to then change. Unfortunately, you know, in the years, you know, people get burnt out, and I've seen, you know, nurses or just talk, you know, and not understanding or seeing that maybe a patient's right there, and then we're talking about them in a certain way. So when they hear that, all that we're doing is reinforcing what they already believe, you know. And I can tell you, if I ever heard that when I was trying to seek recovery, that would be the one thing that automatically says, okay, well, you don't deserve this. You might as well, you know, these people think the same way you do about yourself, you know, hit the door, you know. So it's very important, you know, that we address stigma in a different way, our language, we changed a lot of our language over the last couple of years, changing how we even address alcohol use disorder instead of just calling them a drunk or or they're an alcohol or an addict or a junkie. We're not using those words anymore. And we shouldn't, because they already self-perceive them in that way and perceive themselves in that way, and we just don't want to have to reinforce that. So I think burnout, is a big contributor to this. I see this happen. Someone that's been in the field a long time, they start to get complacent. So it's very important that we take care of ourselves, and understanding that the burnout, and we keep that in check with ourselves, because if we continuously keep that in check, and we'll stay more on top of those issues, and hopefully not let something like that slip. We shouldn't be saying it, but if it is said, it should not be said in front of them patients, because they already truly believe that. And it's our job to change that perception. Why is it necessary to celebrate recovery? Because it's that next step, that achievement that we feel, our yearly celebrations. It's not to say like, oh, wow, look what I got. It's really more of, let's see, look how far I've come through this process, and let's see how far I can continuously go. Look at the stuff behind us and how we continuously move forward. But I want to thank all of you for having me and letting me share, and great for this panel to have me on. Thank you so much.
Thanks so much, Keith. I appreciate you sharing your personal story with all of us, and your presentation gave so much information. So thanks so much for that.
Absolutely.
I'm going to kick off kind of taking where we've left off. We have so many healthcare professionals attending today. We have physicians, dentists, nurses, pharmacists. And one question we continue to get is, what would you recommend to address if a member of a healthcare team is using stigmatizing language or actions towards a patient with OUD or SUD, especially if the member of that team is a higher up? And I know, Iris, you spoke about bias, and Keith, you spoke about bias. So if you could touch on that, and what impact we see. I know you both touched on it, and how can we help our medical professionals? So Iris, I'll turn the question over to you first. Give you a minute, Keith. Any recommendations or things?
Absolutely. We see it in healthcare all the time. And so my goal is to educate and never to shame or embarrass. And that means the other healthcare worker too, right? So I can pull that person aside and talk to them and educate them on addiction, and talk about the brain disease, and talk about the neurobiology, and really try to lift that person up to say, while I know that you might believe that if you say these things, it'll shame somebody into getting better, actually, you just make them want to run from treatment back out to using. And you make it so much harder because they already feel ashamed. They're coming to you ashamed. And so we don't need to kick people when they're down. And so our goal here is to support them. So I really try the educational approach and the compassion approach, because nobody changed because somebody yells at them. And that includes the healthcare worker.
Yes, absolutely. As Iris said, and I actually had a perfect example of this. This is actually years ago when I was a tech, and before you're a counselor, I was a counselor in training, whatever, and a nurse, that veteran nurse, she was there for 20 years. Definitely was my boss. I was not hers. I pulled her aside because she said something, and after I told her, she honestly didn't even realize she was doing it, and it was more of like, once she realized that, she apologized to me, which she didn't have to, but then she also apologized to the patient. And, I never heard her say it again. And she actually thanked me for pointing it out, and it was more of a, I didn't even realize I was, doing that. So sometimes they might not even realize that they're doing it. They might come from different, we don't know, everybody comes from different backgrounds, all that kind of stuff, deal with, different things. They might not even be, an addiction nurse, so it's the first time dealing with it. So, it could be so many different things. But yeah, just as Ira said, just pulling them aside and just making them aware, usually does the trick.
And you both talked about a lot of the shifts and changes and strategy, the stigmatizing language and bringing light to that. How can we bring our healthcare professionals up on those changes in strategy, and how important is that? Keith, you want to go first?
Yeah, education. Education is the biggest key. The more we can educate, the more that we have things like this webinar, different Q&As, just in-house training. It's funny, actually, right now we're about to do our yearly 10 different trainings we have with my organization. Actually, it's like 15 different things, but we have trainings every year that touch on these types of subjects to make sure that, we're treating, because we're also a psych hospital and an addiction hospital. So you have to deal with two different type of patients differently. So we incorporate that education. And I found it to be very helpful. The more organizations that educate, the better care they're going to give. And that they're also going to help move the clients along better and their employees.
And Iris, any?
No, I
recommendations?
1000% agree with that. I think that healthcare workers are overstretched and they're burnt out and they're experiencing compassion fatigue. Working through COVID, things got really hard for all of us. As a therapist who's in a healthcare system, we didn't stop coming to work, right? And so taking care of patients with addiction can be really hard, and your compassion can wear down after a while, but it's recognizing when people are burnt out, shifting their responsibilities, sometimes supporting them, talking to them about the neurology of the brain, even bringing that education that people often don't know when they're often saying, oh, this is substitution, or this person isn't really trying, all of these things, right? They believe them. And then sometimes referring people to therapy because somebody with an addiction has hurt or harmed them, and that's where the anger is coming from. And so I'm like, hey, this is something you may need to work on if you want to continue to take care of this patient population. So just kind of figuring out what is causing the stigma or the bias, and really trying to support them, because just like we're meeting patients where they are, we're meeting the rest of the team where they are too.
Thanks. And I know in the chat we have a lot of questions about how to determine what that correct language is and how they can share it if they don't hear it, preventively, or to get that education and awareness out. So we will, I'm not sure if either of you have any resources you can.
Yeah, I popped the dictionary in there. So the link to the dictionary is there, and it's great and it's up to date. It's recoveryanswers.org, and it gives the latest terms and it defines them for people. So hopefully that's helpful.
Oh, great. And we'll share that information in your post webinar email. So we'll make sure we include that link so that you have it. I know we are coming to the end of our time. We're going to launch the poll if we haven't already, if you haven't seen it already. I just want to mention before I give you one last chance to leave a comment for all of those in attendance, that we hope that as we come to the end of Recovery Month, next month in New Jersey on October 6th, we celebrate Knockout Opiate Abuse Day, and we look at ways to address that crisis specifically. It is on October 6th, which is a Friday. And so our webinar series will be on that day, on October 6th, which is a Friday. So I know for those of you who join our webinar series all the time, we usually always have them on Thursdays. Next month, October 6th, it will be a Friday. And credit information will be provided post this this conversation, and this poll that you just took now does not entitle you to credit. You have to follow the steps of your individual provider. I know we're at the end of our time, but Keith, I'll go to you. Can you leave us with one final thought for our attendees?
Yeah, I just first like to say thank you for coming and doing this and listen to me. one thing I can leave you with is, just enter your work with empathy and care. Love makes the world go round. The more we treat others with kind and respect, the better the world will be.
Thanks so much, Keith, and thanks for being with us today. And Iris, last comment for the day.
Yeah, I want to encourage people to do the research. Look at the evidence, look where it's pointing to, look at mortality. Before you decide that one thing is recovery or isn't recovery, or one way is the way, please just, look at the research. It's readily available out to us there, and you can see what interventions work, what's effective, and we can make decisions based off of evidence rather than our morals or our bias or our own experiences, which often happens in this field.
All right, thank you so much. Again, thank you to our expert panelists. Thank you for sharing with us. Thanks for sharing your personal story again, Keith, as we look at celebrating this month, Recovery Month, and all that have accomplished. And we look at eliminating stigma. And when we see someone like you who's willing to share their story and who's making such a difference in the world, it's inspiring to all of us. So appreciate that, and appreciate you being with us, and appreciate all of our attendees who are here with us today. I know so many of you are in the field trying to get this word out there. And I know we talked about burnout in the healthcare community, and I know there's burnout in the addiction field as well. So thank you so much for joining us, taking the time today. I truly hope that you can be part of Knockout Day on October 6th. There's many ways you can be involved, whether it's just sharing a message on social media, an email. We have a whole toolkit of resources. And so I welcome you to be part of that. And I look forward to seeing you again, hopefully on October 6th. Have a good day, everyone.
Bye, everyone.
Bye.